Welcome everyone from all over the world. It's great to see everyone here.
Greetings for all. I am Manar Hussein, Senior Embryologist at Ganin Fertility Center in Egypt. Of course, our work habits and the protocols have been changed due to COVID-19. For our staff, the regular checkup is a must, by set of blood examinations and specific COVID-19 IgG and IgM rapid tests. Also, our patients must be screened. Daily intensive disinfection for the lab and the equipment. And we have restrictions of movement inside the clinic. It's only one-way direction, and no kids or old people are allowed to enter the clinic. Daily temperature screening for everyone who comes to the facility, either they are patients or our staff, by an untouchable infrared thermometer. All staff and patients must wear face masks and hand sanitizers everywhere inside the clinic for frequent sterilization. We are limiting the physical presence of patients inside the clinic by arranging online calls or Zoom meetings. And due to this pandemic, our number of cases have been dropped and decreased from 7 or 5 cases per day to 2 or 3 cases per day, and sometimes only 5 cases per week, which results in longer time between cases with larger social distancing, and no cases are overlapping. And finally, I want to say for everyone who can't stay at home, stay safe and keep distance.
Thank you so much. With a warm thank you to our colleagues in Egypt for starting this session. Hello and welcome to the 35th session of the International IVF Initiative, or I3, entitled COVID Strategies. My name is Mina Alikani. I am the Senior Director of Northwell Health Fertility Laboratories in New York, and I have the pleasure and honor of co-moderating this session with Dr. Alison Campbell. Alison is Group Director of Embryology at Care Fertility in the UK and Ireland, where she leads 12 embryology laboratories and a team of 80 scientists. A small job, right, Alison? Right, so as usual, we have a great program planned for the next 90 minutes or so. We count on your participation, so we encourage you to ask questions. We have a talented team working behind the scenes to pose your questions to our speakers and panelists. Please remember to ask your questions using the Q&A section of the conference service and not on the chat function. Some questions will be answered live and others in the Q&A section. Our theme today is strategies for coping with COVID-19. We asked you to send us videos on how you have coped with the COVID-19 pandemic. As would be expected, ART clinics around the world have adapted to this new normal. Some common themes have emerged as people have shared their experiences through publications and forums like this. But there are also unique approaches being used that might be of interest to the community at large. We now invite you to watch the next videos in the series, one from Lister Clinic in central London, and the other from San Diego Fertility Center in San Diego, California, USA. Enjoy.
Hi there, I'm Emma Whitney. I am one of the senior embryologists at the Lister Fertility Clinic, which is housed in the Lister Hospital. We are based in central London, which is close to London Victoria Station. I'm just going to take you on a little tour of how it is now. We are COVID secure. Everyone is expected to come through the main doors. There are no side entrances anymore. Staff used to go in the side entrances. And we have to have our temperature checked when we come in. Hiya. Good morning. Perfect. morning. Everyone's expected to pick up a mask at reception, and then they're buzzed into the hospital. Okay, so we used to have a lot of people in waiting rooms, lots of people queuing in the clinic now. It's fairly empty everywhere, there's screens. I'm just going to walk through. As you can see, no patients waiting. This place used to be absolutely packed. All the chairs are spaced out. Not a patient in sight. We've spread out all our appointment times so that nobody is left in waiting rooms at the moment.
This is Bill Venier, San Diego Fertility Center. Some changes we made since COVID is we did completely shut down for about 6 weeks. So no patient care for 6 total weeks. And then we gradually started coming back and batching patients. But the volume was pretty high, so big stress on the lab. Some changes that we have made since the restart are, of course, social distancing. A lot of our patient care is either by phone or Skype these days, not much face-to-face. We've cut down monitoring days. We see them at start and 2 other times before TVA. And pregnancy checks are usually by home with 1 follow-up with us. If their beta-HCG is less than 100, they will come back. If it's more than 100, they are scheduled for an OB.
As far as the lab itself, we really haven't changed much, except we actually do wear masks in the lab where we have not in the past. So we just use regular masks unless we're talking to patients, and then we change into an N95 mask. But we do use a lot more OSAfe products to clean the lab, mostly at the end of the day, not necessarily in between patients unless there's a spill. Also, we designated the building as one way, so patients come in the front door and leave out the back door, so there's no going in and out of the same door. And then staff go only in the back door and change into scrubs. They take their temperature and write it down on a log. As far as staffing, we do try to best fit social distancing as possible. So our work areas have been divided up, so they're either sitting back to back or diagonally.
Thank you. So that was our second video of this session. I expect there were some familiar sights there. I find it's always fascinating, don't you think, Mina, to hear others' experiences and have a peep into other people's labs?
Yes, absolutely. Lots to learn and absorb.
So I would like now to introduce our first speaker. It's Brianna Calcavecchia. And Brianna graduated in biology from Syracuse University, and she has a strong interest in genetics. She's been working in embryology for 3 years and as an associate embryologist at the Northwell Health Fertility Labs in New York for 1 year. And Brianna's talk is entitled Disinfecting the ART Laboratory. Thanks, Brianna.
Thank you, Dr. Campbell, for the introduction. Hello, everyone. It is my pleasure to present this talk on cleaning and disinfecting the ART laboratory on behalf of my coworkers and Dr. Mina Alikani, our lab director at Northwell Health Fertility Laboratories, New York City. We thank I3 for providing us with this opportunity. We have no relationship with the manufacturers of the products we are discussing today and no other relevant disclosures. The preface to this talk is that the protocols we are discussing here do not specifically address SARS-CoV-2, the virus that causes COVID-19. The literature on this topic is tentative and sometimes confusing. However, we know that this virus is surrounded by a lipid bilayer that plays a crucial role in its life cycle. The lipid bilayer is a target of soap, while the protein components are targets for the disinfectants that we are discussing today. The disruption of the membrane and denaturing of the proteins by these agents is expected to kill and/or inactivate viruses of this type in general. So I'd like to begin with the definition of two key terms we are using today. First, cleaning is the physical removal of organic and inorganic material from objects and surfaces. Disinfection is a process that eliminates many or all pathogenic microorganisms except bacterial spores from inanimate objects. We will not be discussing sterilization. It is important to keep in mind that these are not interchangeable terms. Terms with the suffix "side" or "sidal" refer to killing action and are commonly used. So let's look at what factors influence antimicrobial efficacy. So we have target surface, target microorganism, we have the ambient environment, both temperature and humidity, the disinfectant type that we are using, the wipe material, we have the application method as well as the wiping strategy. So what is an ideal disinfectant? While you're looking at this list, keep in mind that there is no disinfectant or cleaning agent that is non-toxic to gametes and embryos. It is certainly true that some are more toxic than others. Disinfectants should be broad spectrum antimicrobials. They should be safe for the user and the environment, non-volatile, non-corrosive or flammable, stable, and hopefully inexpensive. So regardless of what compound you're using, our advice is to read the safety data sheet carefully. SDS are readily available online and provide specific information on ingredients, safety precautions, as well as handling and storage. So what are we cleaning? First and foremost, we're cleaning our hands. The best and most effective way to clean our hands is with soap and water as frequently as possible, at least for 20 seconds. Certainly before entering the lab, in between patients when possible, and after removal of gloves. Alcohol-based sanitizers should not be used in the laboratory because they generate VOCs and may contain fragrances, dyes, or moisturizers that leave a residue after evaporation of the alcohol component. They can be used outside the laboratory if soap and water is not available, with at least 15 to 30 seconds exposure time. They should be used selectively and in moderation. We have by design no sanitizers on our floor, but multiple sinks are readily available throughout the floor. If you're interested in more specific information on hand sanitizers, you could take a look at this paper here by Golan and colleagues in the American Journal of Infection Control, and they talk about more specifics on hand sanitizers. So alcohols, particularly 70% ethanol, are probably the most common disinfectants used in most laboratory settings. While they're effective, they're highly volatile, and they're able to penetrate spaces and linger in the air, which is why they are not ideal for the ART laboratory. In this 1997 study by Jacques Cohen, Antonia Gilligan, and colleagues, it was shown that isopropyl alcohol, which was not even used in the ART laboratory, had nonetheless penetrated the laboratory from adjacent hospital areas. To avoid this problem, particularly when a good air handling system is not available, it's our opinion that alcohol should be used cautiously, if used at all, both in and around the laboratory. So 2 brands of disinfectant have been commercially available for IVF laboratories, FertiSafe or FertiSafe Plus, which appears to have been discontinued by the manufacturer, and OOSafe. They have very different composition. FertiSafe Plus contains silver dihydrogen citrate, and OOSafe contains quaternary ammonium. They generally require between 1 to 15 minutes exposure time for effectiveness, depending on the level of disinfection needed. These products are typically MEA tested, like many other products specifically made for IVF, and a certificate of analysis is usually provided. In the case of OOSafe, an incubator is cleaned with the disinfectant, then 1 milliliter of the solution is placed in a dish inside the incubator. A mouse assay is run in the same incubator, growing 1-cell embryos for 96 hours and assessing blastocyst formation rate. Controls are cultured in a different incubator. A 70% blastocyst formation rate is considered the minimum acceptable rate. So in this certificate example, you can see that the control test shown on the bottom right here is showing 100% blastocyst formation rate, while the test here shows 95% blastocyst formation rate. So this 95% is considered a passing score. There is unfortunately a lack of studies on disinfection in IVF, but we were able to find 2 abstracts on the topic. The first is a 2007 study by Ronnie Jensen's group in Belgium. They exposed media and dishes to FertiSafe and performed mouse IVF and culture to assess gamete and embryo toxicity, concluding that FertiSafe was safe. They also assessed effectiveness in comparison with a 7X solution and concluded that FertiSafe was an effective disinfectant. The second study is by Kat and colleagues at Monash University in Australia. In this study, embryo toxicity and bactericidal efficacy were assessed via direct contact, residue exposure, and incubator cleaning. The investigators concluded that under their test conditions, hydrogen peroxide reduced blastocyst development compared to OOSAFE's quaternary ammonium compound, but that the quaternary ammonium compound left a non-toxic residue after incubator cleaning. Clearly, these results need to be confirmed and expanded in other well-designed studies. In particular, hydrogen peroxide should be better considered and assessed. Compared to water, hydrogen peroxide has an extra oxygen atom. It has strong oxidizing power. It's bactericidal and virucidal. It is relatively safe for both the user and the environment. And since it degrades into water and oxygen, it does not leave any potentially toxic residues after use. It is, however, an irritant and should be handled carefully using appropriate PPE. So our protocol for the use of 6% hydrogen peroxide for disinfection of laminar flow hoods or workstations is outlined here. First, we clear the surface of all objects. Next, we very carefully spray or squirt distilled water on the surface and wipe off using a Kim wipe. Now we're ready to use our hydrogen peroxide. So we again very carefully spray or squirt hydrogen peroxide to cover the surface to be disinfected. We set a timer for 1 minute to allow for proper contact time. And after 1 minute, we then wipe the surface again with distilled water to physically remove any microorganisms that have been killed or ousted. The laboratory environment, including floors, is another point of focus. During lab shutdown periods, we have a vacuum equipped with HEPA filtration to vacuum the floors. This is followed by either steam cleaning and or mopping with 6% hydrogen peroxide. And then that's also followed by mopping with water again. So you can see we have our vacuum here at the bottom that we use in our laboratory, and that's followed by the use of our steam cleaner, which you can see here. So while we're in operation, we clean the floors weekly by mopping with water only, unless there's some sort of spill or disinfection is required. The area immediately outside the laboratory is mopped with water for cleaning, then disinfected with hydrogen peroxide, then cleaned again with water. Our lab is also equipped with a sophisticated air filtration system that continuously filters the air in the laboratory and procedure rooms throughout a series of activated carbonate and permanganate canisters housed in this unit, and you can see this here. So this unit exchanges the air at a rate of about 25 changes per hour with 10 to 15% of fresh New York City air. And this is our laboratory at the end of a workday. We like to keep it clean and clutter-free always. So to sum up what we've discussed here, some key points to keep in mind when disinfecting the IVF laboratory. Select a disinfectant that works for your laboratory carefully and with full knowledge of its properties. Consider the timing of disinfection. Most disinfection can be done at the end of the day, while we can do cleaning during operation hours and while gametes and embryos are being handled. Avoid overuse of the disinfectant, but make sure you're using enough so that the disinfectant can do its job. And lastly, avoid alcohols in the IVF laboratory whenever possible. I would like to acknowledge my colleagues at Northwell Health Fertility Laboratories, New York City, for their contributions to this presentation. And we would especially like to thank Antonia Gilligan from Alpha Environmental for her advice, expertise, and friendship. And please note that all of the photos you see here were pre-COVID photos. We no longer enter the hospital, laboratory, or offices without a mask. So thank you, everyone. Please be safe and please remember to wear a mask.
Thank you, Brianna. That was an excellent presentation. Really, really nice slides. Now, I was thinking it's unfortunate that we don't have too many embryo-safe alternatives for cleaning our labs. And I wondered what you or Mina could advise to people who may be experiencing shortages in their preferred lab disinfectants, and they might be afraid to try something new. So you know what we're like, we don't like change too much, and we're happy with one product, but in this current time, shortages could be an issue. So have you got any advice for people in that regard?
So, I mean, our advice would probably be to just get as much knowledge as you can on all of the disinfectants that are available, because there are more than we may think at first. You know, I know there's only so few disinfectants specifically made for IVF on the market. However, our preferred disinfectant is the 6% hydrogen peroxide. Thankfully, we have not experienced a shortage of that, but if we had, there are other options that we could use specifically for hydrogen peroxide. If we were experiencing a shortage of the 6%, we could always go for something with a higher concentration, like a 30% hydrogen peroxide, and diluting it so that we can use that as well.
Great, that's really helpful, thank you. Now, we're trying to be reactive, interactive. We had a nice question popped up during that session, not directly related to cleaning and disinfectant, but it was from Lucy Richardson in the UK, and she was asking whether clinics take temperatures of staff and patients. So, as if by magic, we have a quick poll here for you. So if you'd like to, everybody, place your answers now, and we'll have a look at the responses in a few moments. It's just a quick question. Does your clinic take temperatures of staff and patients?
Alison, does yours? Do yours? It's because you have several.
Yeah, well, we had been, but we're not doing it now. We're doing more a questionnaire triage approach rather than patient code of conduct, staff code of conduct. How about, oh look, the answers are in. Yes, well, the majority in red, 78%, yes, they're taking temperatures of both staff and patients. And then just a few, the minority, patients only, not at all, or staff. How about you, Mina? Are you taking temperatures?
Right, because we are housed in a hospital, all the people who enter the hospital have to answer a questionnaire, and their temperature is taken, and the staff, as we enter, we don't have to answer the questionnaire, but they do take our temperatures before entering. And no one can enter the facilities or walk around the facilities without a mask.
Great.
Yeah.
Right, so I think it's time to move on.
Shall we move on? Yes, okay. So
yeah, we've got our third video coming up. So we'll invite you to watch our next montage, and this describes experiences from our colleagues in Italy, India, and also the UK.
Great, let's look.
Hello everyone, this is Dr. Parshan Gopinath, Senior Consultant and Scientific Director at Saima Fertility Center, Cochin, Kerala, India. The COVID pandemic has significantly changed the way we practice, and we as a center are doing all precautionary measures to prevent the spread as well as infection of any of our staff or patients. At the administrative level, we have reduced or decreased the staff strength to 50%, and the remaining 50% is kept at home. This is to make sure that in case of any exposure to any of these staff to any COVID patients, we always have a backup staff to continue the treatment in our center. With regard to all the consultations, lab investigations, scans, we are giving them regular intervals between these cases so that we are preventing all kinds of crowding and also to follow the social distancing. With regard to patients who are undergoing IVF, we make it a point that all patients, husband and wife, are tested for COVID-19 at the time of starting stimulation and at the time of home pickup. Once these screens are negative, we take the patient for home pickup, and there are also sufficient interval which are being recommended by our local body between these cases so that we can have enough time for cleaning of our lab as well as the theatre in between the cases. All samples, biological samples, are discarded after dilution so that to prevent or decrease the viral load in these samples at the time of discarding. Between the cases as well as in the theatre and the lab, we use quaternary emolling components to clean, and enough time is given between these cleanings so that the cleaning can be effective. We have made it a point that all staff and professionals in the lab and the theatre are equipped with correct PPE that is recommended by our local body. In a situation where the patient is found to be COVID positive or suspected to be COVID positive, we give them the option of either cancelling the cycle, or we give them the option of doing an home pickup and freezing the oocytes and scheduling an ICSI and embryo transfer at a later phase. All the embryos and oocytes that are frozen during this particular pandemic has been scheduled in a separate isolated cryocan because we do not know what is going to be the end product as of now. We hope and pray that more development comes in this field at the earliest so that it makes a procedure more simpler and safer. Thank you so much.
Hi, I'm Lynn Neese, the lab manager at Care Northampton. I'm just going to run through some of the things that we've made changes to in order to minimise the risk to ourselves and patients post-COVID. We've reduced the number of patients who come on visits by cutting down the number of scans, and unfortunately at the moment the partners can't come into their treatment sessions. We triage each patient before we see them, and we try to cut down the time that we spend with patients. In the lab, we have looked at using electronic witnessing rather than manual witnessing to cut down the time that we have to spend close to one another. We all wear this lovely PPE, and we've done lots of things to make ourselves feel safe. We have labelled our pipette handles, our pens, so that we only use those products ourselves. One of the big problems during COVID was the supply of liquid nitrogen and whether or not we were going to get the liquid nitrogen to fill all of our dewars. But we have liquid nitrogen generators in some of our clinics, so our plan was that if we ran into problems with our supplier, then we would generate our own and ship it around the country to the labs where it was needed. We're cleaning more throughout the day, and we are using a closed system for vitrification for any patients who have proved to be positive for COVID-19. Otherwise, we're trying to manage as best we can on a day-to-day basis in the way that we used to. All in all, it's working quite well for myself and my colleagues.
The videos were actually a good segue to the next topic of discussion, which is cryopreservation and storage during the COVID-19 pandemic. So if you give me just a brief moment to share my screen. I will show you. Right. So so unfortunately, our planned speaker, Nuno Costa-Borges, could not be here today. So we would like to engage the audience in this discussion by presenting 5 poll questions to you. We encourage everybody to answer the questions, because the more answers we have, the better sense we can get for the direction of this discussion. And don't forget to scroll down so you can see all 5 questions. Once you've had a chance to respond to the poll questions, then we can look at the results together. So just briefly to summarize what a commentary that was just recently published by Nuno and his colleagues at Embryo Tools highlighted, they discussed a few mitigation options, and of course these are not mutually exclusive. The first is liquid nitrogen sterilization. And we just heard Lodovico Parmigiani talk on that, give us present a video on that, and we know that he's a great proponent of this approach. Then there is quarantine, putting eggs, embryos, and sperm in isolated tanks for the duration of this pandemic, essentially. The third option would be the use of vapor instead of liquid, though I'm not sure if this would make a difference because vapor can presumably be contaminated as well. And finally, the use of closed vitrification systems, which introduces the complication of training and changing of a protocol during a especially challenging time in the laboratories. Again, these options are not mutually exclusive and can be used in combination. So that was really the extent of my contribution to this discussion so far. If we could.
The results are in.
Right. So.
Should we go through one by one?
Yeah, I think so. I'm just trying to unshare my.
Well, I'll start with the first one then,
right.
Which was, do you believe that there is potential risk of cross-contamination with SARS-CoV-2 during cryopreservation procedures? We don't know. Yes, no, and unsure. Also 30% or so each, a third each. So we've got a very mixed response there.
Yeah, interesting. The second question is, have you changed your freezing and/or storage methods since the outbreak of the pandemic? And a great majority, 72%, have responded no. That's also very interesting.
That is interesting, and I'm sure everybody considered that one long and hard. And really, the way we approached it, we thought we need to balance the risks, be proportionate. And if it's not a routine system that you're using, if it's not a closed system that you're used to, then there are risks in changing over, and you need to try and balance them. It's not an easy one, is it?
Right.
The next one, have you changed your vitrification practices to a closed system in light of the COVID-19 pandemic? And majority not. So a quarter already using a closed system, and a small proportion, 15%, have changed. presumably, yeah, from an open to a closed system.
The next question was, do you have a separate tank for storing gametes or embryos in this time period? And again, a significant number of responders said no. They have not allocated quarantine tanks essentially for eggs and embryos and that are coming into the laboratory in this time period.
There's so many things to consider if you're wondering about having separate storage tanks for these patients. No space and need and demand.
Right, right. Well, there's also the point that most programs are testing their patients, and so the question is, what is the purpose here? What's the level of risk that we are facing? And is it worth changing all of our protocols? And the last question.
Yes, so finally, have you treated anybody who tested positive for SARS-CoV-2 prior to egg pickup? So 89% no, 11% have done.
Right, so again, a majority of programs are testing their patients and not putting them through ART treatments if they test positive for COVID.
Yeah, I wonder if any have tested positive once the embryos are in the lab. Then
right, it would be interesting to know, right? And we've not had experiences like that, but it is possible. And then, of course, the question, under what circumstances do you actually treat patients with COVID-19? A few people did respond that they have treated COVID-19 patients. So unless it's an emergency, I wonder what those circumstances might be.
And maybe they resulted in a freeze-all rather than an embryo transfer.
Right. Great. So I think this has been very enlightening, and I'm sure it provides a good sort of setup for the Q&A session as well.
Yeah.
For now, I'd like to introduce our next speaker, Debbie Venier. It's my pleasure to introduce Debbie, who has had a long and productive career in ART as a clinical embryologist with a background in reproductive physiology and animal science. She's based in California, in the USA. In addition to practicing clinical embryology, Debbie has trained many embryologists and started the undergraduate embryology program at Cal Poly State University in California, which is still running. She's currently a consultant and is going to present a talk to us entitled Physically Distant but Socially Connected. Her talk is kindly sponsored by Cooper Surgical. Debbie, please.
Thank you. I want to start by thanking I3 for starting this platform. I think it's fabulous for our lab staff, our embryology staff, to be able to communicate in a time where there's a lot of stress in the lab and in our office and in our homes. So I think it's fabulous what you guys have done. So this is great.
Debbie, you're muted.
Muted.
Yeah,
Was I The whole time?
No, just when you started this slide, for some reason, it just switched.
Okay.
So if you just start.
Okay. So what I want to start talking about is focusing on physical distancing versus social distancing. I don't think that we really intend to socially distance and disconnect from each other, but we do need to disconnect a little bit physically. So I think there's been a lot of stress in our lives at home, at work, in the world, everywhere. And I think it's important to try to keep the peace and the calm in the lab, and try to keep our patients safe and keep our staff safe and keep our embryos safe. So I'm just going to go over a few ideas and topics and points that I think we could utilize and discuss for our lab to give us the best patient care. So the first thing, there's three main topics. This is just a little outline of my talk. Is I want to talk about how we can decrease staff in the lab at one particular time. I know most of us have really small labs. Some of those pictures you were showing were beautiful, large labs, but I think the majority of us really work in a very small lab, and it's very tight with people in the laboratory. So we're going to talk about a few ways to decrease the amount of staff that we're going to have in the laboratory. And then I want to go over increasing space between staff while we are in the lab. If the essential staff are in there, how can we kind of space out a little bit while that's happening? And then the last thing I just want to touch on is maintaining efficiency and communication between the staff. If there's less of us working, a lot of us have reduced hours, we're spacing out, we're not seeing the staff as much as we used to, and communication starts to fall by the wayside then. So a few ideas there, and kind of pointing out in the pictures here on my screen, you know, pre-COVID, no mask, we're all happy, everything's great. And then post-COVID, this was our first picture back after our lab reopened. We went, you know, we had gloves, we had face shields, we were wearing surgical gowns anytime we interacted with patients or each other. And we've eased off of that a little bit, but it was scary at first. So pointing out a few ways to decrease staff in the lab. And some of this was pointed out in the videos, which I was happy to hear, was scheduling. So two different things we can talk about, scheduling with the front office and when patients are coming in and when procedures are scheduled from the front office, and then also scheduling within the laboratory. When are we going to be doing our VIT procedures? Who's going to be doing biopsy? When are we doing ICSI? And maybe kind of shifting some of that so that there can be less people in the lab. So that would be basically spreading out our day. You know, everyone I think would like to come in at 8 and leave at 4 or 5. But maybe if we kind of have an early shift and a late shift where, you know, we're starting to work at 6 o'clock in the morning, and some people are even saying they're coming in earlier at 5, and then have a late crew that's staying till 7 or 8 o'clock at night, which is allowing you to have less people in the laboratory and space out your procedures and have a little smoother flow. The second thing is having non-essential lab tasks performed outside of the laboratory. I think most people will agree there's always one person that's in the lab on a computer doing clerical, you know, data entry, processing charts, processing paperwork, and basically doing office work in the lab. Some labs don't have that person, but most of the labs that I've been in do have someone that's literally sitting on a computer inside the laboratory the whole time. So I think moving that person outside of the lab might space out lab and give us a little more space in the lab. So they could either hopefully find office space. I know, you know, a lot of offices have, you know, accountants and people that are only there Mondays and Wednesdays, and use those spaces on the other days for this clerical lab person. Also looking at potentially performing some of those tasks remotely. I know we have to be careful with privacy concerns and HIPAA violations, but there are a lot of processes and procedures that are okay to perform your data entry and your statistics from home. If you're logging into a secure network, a lot of that is capable of being done from home. Excuse me. Only those people performing the essential tasks in the lab, I think we need to tighten those rules, or a lot of labs probably need to. And I know those rules differ from lab to lab. I know there's a lot of labs that truly always have had a strict policy. Only the embryologists are allowed in the lab, nobody else. But I've also been in labs where doctors are coming in with a cup of coffee and chatting, nurses are coming in, medical assistants are coming in, all kinds of people are in and out of the lab all day. So probably really tightening those rules down and saying, you know what, this is an embryologist only place. Nobody else can come in, especially in the time of COVID. And then another really no-brainer for me was using electronic witnessing. I started using this about a year ago, and really, you know, all of us are double IDing in the laboratory, and having that additional person all the time, hey, can you come witness? Can you come witness? And you always need an additional person in the lab to witness. And this will vary based on how busy your laboratory is and your cycle volume. But even in a small lab, you constantly need someone to witness for an egg retrieval, witness for a thaw, witness for a transfer. So constantly calling someone is really difficult when you have a lighter staff in the lab. So I want to review a little bit about electronic witnessing, because I know it's a little more common in Europe and it's a little less common in the United States. So here we have a photo of just a typical witnessing procedure where two embryologists are double IDing, and you're trying to read your microscopic ELF writing on a dish or a straw, and you're really hovered really close to each other. Granted, they're wearing masks, but it's still not an ideal situation. Probably the next best situation would be in this photo here, where the embryologist has a video monitoring system. So there's a nice clear video where you can see clearly the name, the patient identification number, and the embryologist that's witnessing can stand further away and still social distance. That's a little bit better than the first option, but not having to have that second witness in the laboratory at all is really your ideal situation. So electronic witnessing, which here, this is a picture of the RI witness, which every workstation in the laboratory gets this little RFID reading platform, and all the witnessing is done automatically. Anytime an RFID tag comes into that area, which all of your dishes and the patient has a reader, it automatically identifies what's going on and makes sure that it's only one patient's tissue that is in that area. The embryologist also has an RFID tag. I wore mine on my wrist. You can also wear it on a lanyard, but when you come close to that microscope and you're doing work, it identifies you and it knows exactly what you're doing and what patient you have and at what time you're doing it. So, and it's all done automatically. I don't have to do anything for that to happen. So the RFID technology really allows for seamless flow in procedures with a solo embryologist. Some of the smaller labs, I know a lot of times on weekends and slow days, there might only be one person in the laboratory and it's hard to find a witness. Sometimes you're calling a doctor in or a nurse to cover for you, but with the RI witness, your witness is there and you're good to go. It does document all of your procedures, the times, and the auto recognition of the embryologist. You have a complete chain of custody. So at the end of a cycle, you can print out a sheet and it has the exact times that everything was done and that there was no other tissue in the area. It will report if there was a mismatch, and that report only is a confidential report. Mismatches will occur if you do bring two tissues into a work area that are not belonging to the same patient. Husband and wife are matched. You also have egg donor and surrogates that are matched to patients as well. So it's smooth with egg donation, it's smooth with surrogacy. It all matches to the appropriate patients and it keeps track of all of that. And the great thing about it is it doesn't disturb the breakup or flow of the embryologist. You know, it's very annoying. And I think a lot of you guys will understand when, you know, you're in the middle of a vit and someone's like, I need a witness. And you're like, okay, my vit's almost done. I have to load, give me a couple minutes. And then they're waiting with embryos out on the dish, on the stage, where they're waiting for you to witness, but you're trying to hurry up and load your vit so that you can go witness them. And it really kind of brings a little bit of stress to have that extra witness all the time. So it really solves that. And it really kind of improves efficiency of the lab altogether. So this is a video of the lab in La Jolla where we installed Witness. And here you can see a picture of the card reader. So this card reader was installed on the side of our hood. And anytime the patient comes in for an egg retrieval or for a transfer, they have their ID card and they're told about what that it's a RFID card radio frequency, and it gets inserted into the microscope where we're going to be working with them. It comes up on the monitor in the room that they're in, their name, their birth date, and then they see under the microscope their dish, and they know that it's not only ID'd visually by us on the monitor, and it's also ID'd by the witness system. So that RFID card reader connects to that microscope, and once that card is in there identifying this patient is in the room, no other tissue can be brought into that area without a visual alarm or an audible alarm going off. So it's really peace of mind. And the patients love it. When they get that card, they're like, oh my gosh, good. So I'm gonna know that I'm getting my embryos, because that's one thing they always ask at transfer is, how do I really know I'm getting my embryos? And with this, it's like, okay, I'm not only confirming that these are your embryos, but this card is gonna go into this microscope and it's only gonna allow tissue from your entire cycle that's been tracked the whole way to be transferred. So it's very positive for them. So this is just a video of the lab showing every workstation having the RI witness attached to every microscope. So there's no place where you can mistakenly switch up somebody's embryos, because every scope has this system. So it's very nice. So this is a picture of the RI witness. This is the tag reader. I know some people were asking about freezing, because you can't freeze an RFID tag yet. So this is a scanner. So once they go onto the cryo devices, they are tagged by embryo number, not by just the patient, but actual by individual number. And you scan in each straw to tag it to each individual embryo. So it's the RI witness will witness retrievals, ICSI, checks, transfers, freezing, and thaws. Now, a question did pop up in the triage there. I saw someone was asking about, what about biopsy? I know they are working on that technology currently, but we do still currently second witness for biopsy embryos. Okay, so increasing space between your lab personnel, excuse me. Taking a look at your lab layout and seeing if there's not some ways in your lab that you could space out the flow of your laboratory. I thought this was kind of a perfect example in this picture here. It looks like there's 3 andrology scopes all right on top of each other, which is great, but they're way too close for these times. So one, I would suggest simply spacing those out further on that table, because the table can certainly accommodate more spacing, but also maybe taking one of those stations out and only having 2 stations there at that table so that there's not more than 2 people. So simple things like that, where you look at your lab and you're like, okay, how can we kind of decrease the amount of clutter and people elbow to elbow in our laboratory? Another thing I think might be helpful in some circumstances is what I call single tasking, which is where you have one person doing the same thing the whole day. They're in one section of your laboratory and they're doing VIT the whole day, and they're just staying in one little location, and there's not all this crisscross in the lab and TikTok and people going everywhere. You have one person doing ICSI and they're just at the ICSI station all day. And I know some of the larger labs probably already have that policy, but I think a lot of us are in smaller labs where we're doing everything and we're changing up what we do all day long. So I think it might be, for the time being, which I know as an embryologist, I don't really want to sit and do the same thing all day long, but given the circumstances, if it's going to be safer, I would consider doing that. Rotating lunch shifts, you know, if you're stretching out your day, maybe your early people can take an earlier lunch shift, later people, instead of everyone going to lunch and hanging out at lunchtime at noon, separating that out and utilizing maybe conference room space, which usually that room sits empty, or an empty office, or just an empty area in the lab. Try to utilize all of those spaces so that the high flow areas are less congested. Okay, and staying socially connected. This is where I think, with all the spacing out, the decrease in hours, and us not really seeing each other in the lab the way that we used to, we really need to make sure we don't have a breakdown in communication, because we know a breakdown in communication in the lab could be horrible. And there's always that special patient that, oh, you know, so-and-so changed her mind and she wants to do this instead of that. And usually, sometimes that's just a verbal in the lab. And if everybody's not there and you leave early for the day and the late shift is covering something and there's not communication there for that to happen, that could be potentially very dangerous. So maybe having some type of a special communication board where everyone's communicating for the day, a list of what happened, what were the changes for the day, spreadsheet check off. And I think, obviously the regular lab schedule that everybody's following is there, but keeping track of, we always have people changing their mind at the last minute. Oh, she wants to biopsy 12, not 8. She doesn't want to biopsy anymore. She doesn't want the fresh, things like that, where there can be this breakdown in communication because we don't have the lab staff there. So instituting some type of communication board in your lab that works for you guys, I think could be really important. Zoom calls for check-in, I think is good for the lab. If we're not seeing each other and we're rotating days, and I know some people are still even working in 2 separate teams where we're really disconnecting socially, and we need to think of ways to do that. So maybe, a weekly check-in, a daily check-in, and every couple of days check-in where you all get on and everybody, is everybody okay? Was there any breakdowns in communication this week? Let's keep the flow in the lab going smoothly. FaceTime calls, I think someone had mentioned this a while back, that they're FaceTiming through the office. So instead of running out to the nurse's station to ask them a question, you just use your FaceTime and you call them while you're in the office. You're both in the office. And that works well for some people, and you can stay connected. I think seeing someone's face really is helpful than just a text like, hey, what's going on with this person? But if you give them a FaceTime call, you connect a little bit more. I know someone did ask about FaceTime for witnessing. I know some labs do that. Excuse me, again, I'm recovering from a cough. And again, there's some privacy concerns there, especially if someone's taking a FaceTime call in the middle of a grocery store and you're talking about a patient or something like that, where the privacy just isn't there. I don't think that is used at all in Europe, but I know it is used somewhat in the US. And again, it depends on where you're taking that call and what HIPAA violations might be involved. But it's something to look at. And then leadership support. I think this is more a time than ever to stay connected. And I think we need to count on our lab directors and our doctors and our CEOs in our office to really have that positive encouragement and make sure that we stay connected as an office, that everyone is, even though we're not really seeing each other, we're not hanging out by the water cooler anymore, we're not going to happy hour after work. So we do really start to feel socially disconnected from the office and disconnected from our work. And that's not the point at all. We need to be safe. We need to be physically distant, but we really need to try to keep the morale up and keep in contact with each other. So I definitely think it's important for the senior staff to influence that. And that's it. I just have a little funny here. Those of you that are young may not even know what the Brady Bunch is, but this was like the first original Zoom call back in the day. So my point here is stay connected, stay safe, but physically distant.
Thank you very much, Debbie. That was a great talk. I wonder if I can ask you about the RI Witness, the system itself. You showed that there is hardware associated, of course, with this system.
Yes.
So do the hoods need to be permanently modified?
So there's 2 options. If you're buying a new hood, you can have your RI Witness installed completely flush right into your hood. But we already had our hoods. So we had it installed aftermarket. And you could see there, it's a little less than an inch, maybe 3/4 of an inch. And that was one thing we were actually really concerned about. One of our main concerns when we got it was like, oh my gosh, what if a dish falls off the edge? What if blah, blah, blah. But it was not an issue for us at all. We never had a scare. We didn't have an issue. It's actually very wide, and how we work under our scope and where I normally set my dishes was actually within those spaces of that platform. So it wasn't an issue. Yeah, you can install it flush or you can install it aftermarket with your existing hoods.
Oh, excellent. And then the reader is separate and it sits outside of the hood.
Yeah, you can put the card reader.
The card reader.
Yeah, you can put the card reader in the OR. You can put it in your embryo transfer room. You can put it in your hood. You can put it up above. You can put it, well, they can install it anywhere.
Right.
So Debbie, the card is there really to link directly to the patient. So that's at the point of egg recovery or sperm delivery, and then back at the end for embryo transfer.
So, and the patients, their response to it is amazing. They feel so good, especially after the recent news events. Well, it's actually been like a year now, but where there was mix-ups with babies and everyone's coming in for transfer. Like, I'm so nervous. I don't know if I'm getting my embryos. And this just gives them amazing peace of mind. So that's probably my favorite thing about it, is actually the peace of mind that the patient gets.
So Debbie, one other thing. These systems, RI as well as the others that are on the market, are still ultimately directed toward containers, right? From when you go from dish to dish, from a tube to a dish, etc. They're not geared toward, for instance, a biopsy case. So when you're doing a biopsy case and you are vitrifying biopsied embryos, which has to happen individually with great care, you still need a human witness. Correct?
You are, it's still, your biopsy dish is still tagged with an RFID tag. After biopsy, it's all still tagged. So it's still keeping track that this is the same patient. So there is a chain of custody of the patient. The embryo number doesn't go into the system until you actually freezing when you're scanning. And then it does do individual numbers. So the problem is you have, at least in most labs that I've been in, the biopsied embryos are all in one dish. They're individually cultured, but they're in one dish. So I know Cooper is working on some technology to be able to RFID each drop. So that's to come.
That's really the key for this technology to be really useful for biopsy. And considering the proportion of patients that are now going through PGT, I think this is a key. And it's extremely important to keep track of the identity of individual embryos.
That's something I've definitely been pushing them for. Even before we decided to go with it, I was saying, what about biopsy? What about biopsy? And they're like, we're on it, we're working on it. So hopefully soon we'll hear something great for RFID of individual embryos after biopsy. But yeah, I think for us right now, just knowing that the embryos are tracked, we don't have to have a witness in the lab. When we're doing an ICSI on a weekend, you go in for a retrieval and an ICSI, and one embryologist could technically do that on their own and be completely secure and witnessed. Right. But yeah, if there's a biopsy case, then you have more to work with.
Great, thank you so much. That was very, very informative. Alison,
yeah,
you've got another video for us.
Yes, I have. So before we move on to another quick poll later, let's have a nice fourth and final video of this session. And I think it's amazing. I'm sitting here thinking what a wonderful thing that we're doing, and Debbie's sentiment that keeping connected is so important. Absolutely agree. Sharing our thoughts and practices at this difficult time is a really positive thing to do.
Yes.
So I'd like to invite you all to watch another video montage. This is from King's Fertility and from Care Fertility in Nottingham, both in the UK.
Hi everybody, my name is Anastasia. I'm the lab manager at King's Fertility. What we have changed here at King's Fertility for COVID is, apart from the masks and all the screening, in the laboratory we've also tried to minimize the number of people that rotate between hoods. So we'll allocate a person in each hood so that there's no mixing of different and touching between people and equipment and also pipettes. So we allocate all the pipettes for the day in each hood as needed, and at the end of the day we deep clean the hood. We also have So that's to minimize the cross-contamination through touch, and for the droplets through air contamination for COVID-19, we wear masks. We keep a distance of 2 meters between staff, and also we have a really amazing air system, the first in the UK and Europe, live air coming from America, that it really decreases the percentage of contaminants. It has UV, it has 20 air changes an hour, it has a lot of filtration, so the air that enters the lab is changed quite a lot, and also it's very clean. We have class A air, quality of air, and we're very happy about that. I hope you keep safe, everyone.
Hello, I'm Catherine Beresford from Care Fertility in Nottingham in the UK. Care is a group of 11 IVF clinics from around the UK and Ireland, and we all have aligned best embryology practice. We have also implemented extra precautions, such as our own pipette handles for manipulations, and also touchscreen pens for when we are using monitors. We've also increased the amount of cleaning and wiping down of high-touch surfaces like microscope and incubator doors. We have also introduced a new practice for our patients who have not elected to use time-lapse imaging. This new practice provides a more continuous culture of embryos after fertilisation check. In fact, we do not disturb them to assess them until prior to scheduled embryo transfer, usually on day 5. It is important to state that we were already exploring and planning this change to our standard embryo assessment practice prior to the pandemic, but we accelerated our plans because we could see additional benefits of this in relation to working practices and physical distancing of our scientists. We had the confidence to implement this do not disturb policy, as we have been time-lapse users and researchers for many years. We know in our hands which embryo developmental events, timings and morphologies relate most with embryo viability, and how unlikely we would be to observe exactly what we needed to assess when we make static, carefully timed observations. We also considered the impact of removing the cultures from the incubators and balanced the risks and benefits of doing this. This is going really well, and the benefits for workflow and traffic within the lab have also been significant. We've been able to minimise staff in the lab, touching of incubator doors, dishes, pipettes and telephones as a result of this practice. Patients have been very satisfied with it and like the fact that their embryos are being undisturbed, and also the blastocyst quality and implantation rates are very strong. We are constantly reviewing our data and patient and staff feedback regularly. Currently, about half of our patients have time-lapse imaging and half have our do not disturb standard incubation approach.
So Alison, would you like to start the Q&A session? We have a few minutes left. We could pose some of the questions from the audience. Would you like to start, or would you like me?
I'm happy to. I think we've got a surprise mini poll to pop up first. Yeah,
okay. So you're a surprise to me.
I feel like a magician. So this question came in from Mitch, asking about staff with COVID. Question being, have any of your lab staff had COVID-19? And if they have, was anyone else infected? So it's just a quick question so we can have a chat about the results. Be good. Thank you.
Right, and I saw a question about what do you do if one of your staff members tests positive for COVID. Do you have a protocol, Alison, for how to deal with it?
Yeah, well, I say it's we're following.
Oh, there's your cat.
Yeah, that's Charlie the cat. So we're following government advice really, and it's very similar to what's happening in the schools. Back in March, I knew nobody who had tested positive, and now we've got 2. Oh goodness, the cat's walking along the banister. It's a really big drop behind there, so don't let me look.
That's what they do for a living.
I know. So hope there's not going to be a big crash. So yeah, it's about proximity. If the embryologists are working spaced out with the masks, they're not coming into close proximity of each other, and one tests positive, then we'd assess if there were any other staff members at risk and what's been happening the preceding days, probably do precautionary testing as well, and certainly isolate the member of staff that has been affected who's tested positive. Yeah, my daughter's, there are 2 classmates have tested positive, so they've sent home everyone who sits around them. The children aren't moving from class to class, so we'll see how this pans out, but we don't really know at this stage. Oh, the results
We've
back
got
now.
the results. Right. So 74% of the respondents said that they have not had any staff members who had COVID-19. And of course, of the 18% who said yes, they responded that 30% responded that the others were not infected. So the question is everyone doing testing of their staff on a regular basis? We are not.
No, we're not. I don't think so. I mean, well, certainly in the UK, doesn't seem to be very easy to get a test. They're not readily available. I think the turnaround time is quite slow. We don't have surplus tests to just test broadly at the moment.
Right. So let's go to the, by the way, if any of our other panelists would like to add to this discussion, please feel free. I know Kelly is hiding somewhere in there. So Kelly, please feel free to join the discussion, and anyone else really.
Well, there's a question we could ask, sort of going on from talking about staff numbers to Debbie. Debbie, do you think that the use of electronic witnessing can be used to reduce staff in other departments aside from the embryology labs, nurses, for example, or in the theatre?
Yeah, so to some degree, when we're like identifying at the time of egg retrieval, we typically have the timeout in the OR with everybody, but now the embryologist can go in and meet with the patient and get their identification card from them directly and just put it right in the scope, and then the lab is done. So that's one step less that embryologist and the OR staff doesn't have to be involved with. And then same thing at transfer time, typically we're identifying with a nurse as well. And we don't use the nurse anymore. I mean, the nurse is there for the transfer, but at the time of patient ID, the embryologist and the patient with the identification card is all that's necessary. So that helps out a little bit.
Alison, we have a couple of questions regarding Brianna's talk and the disinfection of laboratory, etc. Judith Menezes from Sweden is actually telling us that there is a product called Embryo Safe, where the main ingredient is hypochlorous acid. I am not familiar with this product, but as we mentioned, I think there is the problem in this area is a lack of studies. And as we mentioned, we were able to find 2 abstracts, not even full papers, on testing of various disinfectants in the IVF laboratory setting. So I think first and foremost, we need more studies to identify which may be the best reagents to use. And if there are other products on the market, by all means, I think if the testing has been done, then yes, you can adopt those. But again, as we mentioned, I think it's important to understand what they're made of and be sure that you understand how they should be used and their limitations. There are questions about alcohol and the use of alcohol. If you have a good air system, can you use alcohol? And I would say, well, it's if you have a good air handling system and lots of air exchanges, like we have here, 24 air exchanges per hour, it makes it less likely that the alcohols would linger in the air inside the lab. If you don't have it, of course, the likelihood is much higher. But I would still be cautious, and I would still advise to use alcohols only at the end of the day or when you don't have eggs and embryos out and exposed. That would be my advice. I'm not sure what you think, Alison. Do you have
exactly. Yeah, no, I exactly the same as you, really. I was thinking 20 years ago, it was quite normal to have alcohol, or maybe we should have to paper sooner. The smell of 70% alcohol was very familiar. Now, not at all. But then I was wondering also, with our Do Not Disturb system, we don't have cultures out of the incubators very often at all. So providing they are safely sealed and gases are filtered going in and circulating, then maybe if we were desperate, but at the minute we have embryo safe products that we're quite happy to use.
Right, so you do use embryo safe? You said?
Safe, it is embryo, we use safe.
Oh, safe, all right. So that the product, I'm assuming that the product is called embryo safe, but maybe we can find out more about that. Any other questions that you are dying to pose, Alison?
I'm dying to pose. So many questions coming in. There's a nice one for you, Mina, here about, we know you've published in this area. Again, it's going back to staff numbers. What's the minimum number of embryologists that we should employ in a centre doing approximately 500 cycles per year?
Right, so I would refer you to the calculator, which, by the way, does need revision. It needs to be updated. That was published in 2014, and practices have changed, and we need to update it in our spare time. I think we'll get to it. But in the meantime, you can actually go directly into the calculator, put the precise numbers of procedures, and it's not just cases, like a generic number of cases. We specify what type of cases, whether it's FET, PGT, oocyte freezing, oocyte thaw, etc. How many incubators you have, because that will affect the amount of time you have to spend on QC. So all of that information you can input into the calculator, which is available on the Fertility and Sterility website, and then it will give you an approximate number of individuals, but the very minimum number of people in the lab that we always advise, regardless of the number of cases that you do, is 2. You simply don't run an IVF laboratory with 1 person, and that to me is a very important point. So maybe we've got time maybe for one more question, 1 or 2 more questions. I saw
how about this one? Is quite interesting. How do you make sure that things brought into the clinic from external areas are safe? So dry shippers, for example, and consumables. Even the postman won't hand you a letter anymore, or post lady. She puts it down on the floor and takes a photograph. So I wonder how people are coping with deliveries, and particularly cryo shippers that you can't just leave on the doorstep.
Right. Bree, do you want to respond to this one?
Yeah, sure. So I think that the most important thing here is that we're remembering that we're dealing with a laboratory. So just because of the pandemic doesn't mean that we should be extra careful. We should be extra careful with external deliveries all of the time. So I would say when we're receiving consumable packages, we could use appropriate PPE, maybe take the package while wearing gloves. And even then, we wouldn't bring the packages directly into the laboratory. We would unbox in the hallway and only take internal boxes into the laboratory when necessary. So that's what I would say as far as consumables, just never bringing anything external into the laboratory. As far as dry shippers, that's a different story, obviously. But what we can do would be to wipe clean the shippers outside the laboratory before bringing them in, and just practice safe handling, safe, clean handling.
Right, very good point. So, I think it is, as Bree mentioned, that we never, ever bring cardboard boxes inside the lab. And that's just common sense and good practice anytime, not just during this pandemic. These are practices that are important anytime. And cleaning of anything like a shipper that comes into a very clean lab before it comes in is again common sense, and it's good practice. So, Alison, do you have anything to add?
No, I was just thinking of moving on to similar theme, but to Debbie. There's a question from John Phillips. Yeah. What do you see the future of RFID in cryotransportation and logistics?
I'm not the engineer. From what I hear, they're saying they're going to come up with an RFID tag that can be submerged in liquid nitrogen for extended periods of time. So I think, I don't know if anybody's heard about the Tomorrow tank, but the Tomorrow tank, everything's RFID'd, and it's in vapor, and they're tracking every single specimen, thousands of specimens all in one tank. So I think that's probably our future for cryobiology.
Yeah, I agree. I think there are a few possible systems out there, and it makes complete sense, doesn't it, to continue the traceability between clinics as well as within the clinic walls.
Yes.
So before we close, 2 things. We have one question which I'd like to bring up, and also let everybody know that we will provide the answers to as many of these questions as possible later on, and they will be available online. So the question is, with the economic hit that centers have taken this year, are you all skipping Christmas this year and working through it? My answer would be no. We're not skipping Christmas or holidays in general. I don't know about Debbie and Alison, your many laboratories. Are you shutting down?
Yeah, no, I completely understand why we could be asked that question. It's been a very tough year, and clinics,
yes,
you could argue that they want to stay open, they need to stay open, patients want treatment. So I think it depends really if clinics have managed to deal with the backlog of patients. I think that's probably the first consideration. Patients always first, but second consideration is the staff welfare. It's been a really tough year. People were furloughed and many didn't cope very well with that, understandably, and others were working skeleton staff, which is also very demanding. So I think not to have a Christmas break would be very tough on many people.
Right. Debbie, yes or no? We only have for a yes or no answer.
I think yes.
You are going to
have a Christmas
break. Have a break. Excellent. Okay, Alison, you'll close the session for us.
Yes, thanks, Mina. So I'd just like to thank everybody for taking time to participate in this session and discussion. I'd particularly like to thank the speakers, Brianna and Debbie, for their excellent presentations and contributions, and to Mina for co-moderating. Thanks also to the organising committee of this initiative. That's Peter Naj, Thomas Elliott, Shaista Sadruddin, Jack Cohen, Marianne Schwertz, and Giles Palmer for organising this really wonderful interactive session. I've had fun anyway. There's a tremendous amount of work goes on behind the scenes, and you can imagine, to try and pull this off. So thank you for the huge amount of time that everybody spends on this endeavour. Also, one of the more complicated elements of these webinars is the stream of questions and the way these are all triaged behind the scenes. Today's triage team members were Peter Naj, Giles Palmer, Anne McLaughlin, Shaista Dadruddin, and Kelly Ketterson. So thank you also to them. So this session and the presentations will be available online very soon. We'll also make available in YouTube format other noteworthy videos that we were unable to show from all around the world, including from Georgios Liparis from Westmead Fertility Centre, Australia, showing us that every clinic has its unique challenges. Don't miss that one. Followed by Nordic Clinic in Nigeria. We've got Oasis in India, Palo Alto Medical Foundation from the US, and also Athens University, Greece represented. Thank you to everyone who's contributed videos to support this initiative. Please don't forget that all past sessions of I3 are available on the website ivfmeeting.com. Thank you finally to Thomas Elliott for his superb technical skills in arranging all of this. Please do tune in next Tuesday for a really exciting and special session, number 36, in silico fertilization. It's not quite the usual New Advances session. We'll take a unique look into how a computer visualizes the embryo. It's an augmented reality in the IVF lab. We also have facial matching of donors using AI and sperm bots. So a really exciting session next week. So hoping to see you all soon, and please be safe. Thank you.
My name is George Liparis. I am the Deputy Scientific Director at Westmead Fertility Centre. So we're based in Westmead, Sydney, Australia, which is New South Wales. So I'm going to talk to you about the measures that we have taken in our clinic and in our centre. Of course, when considering what every centre has done, you have to take into account the centre and how it is based and its individual characteristics. So for our centre, we are located within a public hospital. So we are an individual center, a private center within a public hospital. So the changes that we have done might not apply to every single center, but these are changes that we have implemented. So in Australia, we have been a little bit lucky, which the infection rate of the virus has been kept low. But still, with the quarantine being enforced, we had to take measures and we had to make changes in order to adapt to potentially the virus being into high levels within the community itself. So the changes that we have introduced had to do a lot with everything that most of the people are doing, that is applies to social distancing rules and limiting contact. So what we have done is that first of all, we avoided people using our waiting rooms and limiting the number of people that visit our facilities. So first of all, spaced outdoor appointments and only allowing patients to enter when they're having a particular procedure or blood test or ultrasound done. Therefore, no waiting areas are present, no waiting areas need to be cleaned, therefore limiting the entry points of the patients coming in and out of the clinic. Also, because we are in a public setting, Australia itself, when people enter a hospital, they have to be triaged, and this is being done by the hospital itself, and then they get assigned a color-coded tag that they have been triaged properly and temperature is low and they haven't been into any hotspots or in contact with any positive case. However, taking a step further, what we have introduced as part of our clinic is that we introduce another step of triaging, so triaging ourselves, the patients, and also reassuring that the triaging step was done correctly. And also a lot of it had to do with educating our staff, our patients properly in terms of what their expectations are coming in treatment during the COVID times, whether they had to test, how often they had to take a COVID test, also taking into account daily measurements of temperature, because using an infrared thermometer when being triaged might not be as accurate as a home thermometer with the skin-to-skin contact, and therefore all our patients have been asked to take temperature readings on a daily basis before they show to the front door for any type of treatment. So therefore we took these steps to avoid positive patients coming in and therefore stopping the spread of the virus at the door. We also did the same with our staff. So any staff member that got sick had to stay at home, had to be tested, had to self-isolate, and avoid being sick, even if they want to contribute, even when they want to work, make sure that they are home. But what happens when you're trying to contain the virus, but not necessarily, you have to also plan and take into account the potential risks. So in order to avoid risks, we have always asked one member of our staff working from home for at least a week. And therefore, if there was a spread of the virus within the laboratory and within the members of the staff of the laboratory, because sometimes you cannot apply social distancing rules. I mean, most of the people might be familiar with small embryological spaces and the direct contact and how busy it can be, and therefore not being able to abide to social distancing rules. Therefore, if one member goes down, it could be that the whole team goes down. Therefore, one member is always at home. And if the team goes down, then we have a rescue approach as a freeze-off for all the embryos and gametes. Therefore, the patients that are in treatment to have their embryos saved and not being wasted because the staff got sick with the COVID. So that's in a risk approach, that's what we did. Of course, if some centers have the flexibility to divide the staff into teams, that's absolutely better, because they can assure that the clinic goes on without any interruption. But I'm sure that single centers like ours will not be able to facilitate that. An additional measure that we have taken, and again for the reason that we are within the public setting, is that we consider our cryo tanks to be of vital importance. So we thought of a worst case scenario if the supply chain was cut between the company that brings liquid nitrogen to be able to fuel our tanks. Therefore, we acquired an additional feeder tank to be able to manually change it and swap it to sustain the vapor tanks where we freeze our gametes and embryos for longer periods of time, in case the people that supply nitrogen either get sick themselves or either are not allowed entry within a hospital itself that could be the hub of COVID-infected patients and the treatment of those patients. Again, more measures we did is use of telehealth and avoiding meeting with the patients on a personal level. So whenever we can do something over the phone, we have always opted to do something over the phone. And what we have done is that we have assigned the one bed directly to each patient. So therefore, not moving from waiting room to OPU to stage 1 recovery to stage 2 recovery and then to discharge, but having them assigned directly to their bed and then only moving from their bed when going to the OPU and back. Of course, in order to do that, we had to limit the days that we do pickup, just because we share the theater space. We are within a public setting, so we share the theater space with other departments. So we had to negotiate and change the days that we operate. Instead of operating every day, we have to now operate every other day. But in those days that we operate, we have our own control of the theater, own control of the recovery room, and therefore we're able to abide to the social distancing and all the other measures that are required to limit the spread of the virus.
With the COVID-19 pandemic, and as a care providing organization, we have had to modify our working practices and even some infrastructure in order to curb the spread of the virus and ensure the safety of everyone. Temperature check is done for everyone coming into the clinic, including staff. Hand sanitizers are also provided upon entry. The seating arrangements in our waiting areas have also been modified to ensure social distancing. We are known to be very social people in this part of the world. Hugging and shaking are normal forms of pleasantries, and we have had to adjust to social distancing even in our relationship with our clients and among staff. COVID-19 has also come in between doctor-patient relationship. Social distancing measures are now in place in our consulting rooms. The use of PPE by our consultants at all times when relating to clients and even during theatre procedures has also been incorporated. Although previously used to universal precautionary measures, we have had to upgrade to the use of other PPEs such as face shields and disposable gowns, as well as face masks for laboratory procedures routinely. It is now mandatory to wash your hands with soap and water before entering the laboratory, after encountering patients, and after removal of gloves. Disinfection of frequently touched surfaces and areas in the clinic is carried out daily. In the laboratory environment, we ensure to use chemicals such as hydrogen peroxide, a safe disinfectant for gametes and embryos. We have also implemented the use of information on posters and videos within the clinic to raise awareness about COVID-19. There is also a no face mask, no consultation policy in place, whereby we do not attend to patients that do not properly use face masks within the premises.
5th of September, we performed the first oocyte retrieval and in vitro fertilization in a lady positive for COVID-19 disease. I have to mention that according to the regulation in Greece by the National Authority for IVF, all women must be tested with PCR for SARS-CoV-2 before the final triggering, and in the case that the test comes positive, the triggering must be cancelled along with the whole cycle. What happened here is that the lady had the final triggering injection and without having the result of the test, the next morning the test came positive. The lady was asymptomatic and her husband was mildly symptomatic, positive as well for COVID-19. The private unit, because the couple was treated in a private unit, contacted the Ministry of Health, and the Ministry of Health said that if something has to be done, this must be done in a referral center, and as our unit is located in a referral hospital for COVID-19, the lady was referred to us. We decided to proceed because it was not fair for the couple after having the final triggering not to proceed, and I did oocyte retrieval. We took all the preventative measures that must be taken in surgeries in COVID-19 positive, so we used all the equipment, IVEC, we had the 3 spaces, the theater, which all of us had the preventive equipment, intermediate space and the 3rd space, and after that the specimens were moved to the IVF lab. Before we proceed to the fertilization, we tested with PCR the follicular fluid as well as the sperm, because we had a facility in the hospital, and both of them came up negative. So we did the fertilization, and I took 6 oocytes, and we had 5 embryos on day 1, and today we have 4 day 2 embryos. The plan is, of course, to freeze all embryos and to proceed to transfer in a frozen thaw cycle after the PCR of both partners becomes negative. I must admit that it was a very interesting experience, and we feel very lucky that we helped this couple. Thank you very much.